Good morning, everybody, and welcome to today's session. My name's Dr. Isaac Martin. I'm a pediatrician at Sick Kids, and I'll be co-chairing with Dr. Jane Gross here, who's at National Jewish Health. We're really excited today. We've got a good program focusing, I guess, a little bit thematically on epidemiology and detection of infection, but in the setting of reduced sputum production. So we'll be taking a little bit of a macro look and then focusing and honing down on some more micro stuff. So without further ado, I'd like to welcome up the first speaker today, who Lucille Mianowski, who's going to talk to you about the evolution of bacterial lung colonization status after after commencing ETI therapy.
Good morning. Is it working? Yeah. Good morning. My name is Lucille Mianowski. Thank you very much for inviting me to speak. It's a great honor to be here to talk to you about our study on the evolution of bacterial lung colonization after 1 year of treatment with elexacaftor, tizacaftor, ivacaftor, ETI. There are no relationships to disclose related to this presentation. And so on background, so the lungs of patients with cystic fibrosis are very frequently the host of bacterial colonization. Typical CF pathogens are Staphylococcus aureus, Pseudomonas, Haemophilus influenzae, Stenotrophomonas, Achromobacter, Burkholderia, sebaceous complex species, but we'll also be talking about non-tuberculous mycobacteria. So the graph on the left is from the CF Foundation Patient Registry, annual data from 2021, and it's the prevalences of respiratory microorganisms for the last 30 years. And what you can see is on the green line is Staphylococcus prevalence increasing and becoming the first bacteria documented in the US. And the second line, the blue line, is Pseudomonas, and it's been decreasing for the last 30 years and becoming the second documented bacteria in the sputum of our patient in the US. Put the French graph on the right, just to show you that the relative prevalences are the same, with the first line, the purple line, being the Staphylococcus, and the second line being Pseudomonas aeruginosa. So, as you know, ETI has been approved by the FDA in 2019, and it has been transforming the lives of our patients, especially their respiratory symptoms. So we've been wondering what effect it had on bacterial lung colonization. So the objective of our study is to characterize the impact of ETI on lung colonization. So the question is, does ETI change the prevalence of CF pathogens and the overall density of lung bacteria? And we also focused on the effect of ETI on Pseudomonas colonization and on the correlation between clinical improvement and decrease of lung colonization. So we conducted a retrospective observational study in our university hospital in Lyon, France. All adult patients treated with ETI were included, and we collected spontaneous sputum cultures during programmed visits or during exacerbation. They all were centralized at our bacteriological laboratory. So we defined colonization as persistent if more than half the samples were positive for bacterium during the year, intermittent if less than half the samples were positive for bacterium during the year, and the patient was considered as free if none of the samples was positive for a whole year. And because the study is retrospective, the samples were collected whether the patient was symptomatic or not. And the graph you can see is the design of the study. So we've been collecting sputum cultures for 3 years before ETI introduction and the year after. And the year before ETI introduction is named year 0, the year before year -1, and the year before year -2. So we included 198 patients. The median age was 28.8 years old. We had a higher proportion of males, about 61%. All of our patients had at least one DF508 mutation. That's 122 patients being homozygous, 62%, and 38% being heterozygous. Most of our patients had treatment with a prior modulator, 107. That's more than half of our patients. And most of them completed a full year of treatment in our center. Only 3 patients did not complete a full year of treatment. One suspended treatment for 2 months and then resumed it without any adverse effect. One moved out of the region, and one sadly died of an unrelated cause. But all were analyzed within the cohort. So this is a slide on our clinical outcomes. So the first graph, 4B, is lung function, with the bottom line being percentage of predicted FEV1 and the upper line being FCV. And you can see that both of them are very stable for the 3 years before ETI introduction, and both of them increase after ETI introduction. The second graph, 4B, is the evolution of pulmonary exacerbation and the evolution of prescribed physiotherapy in times per week. So the upper line is prescribed physiotherapy. We measured that because it reflects the productivity of our patients and the quantity of mucus. And the bottom line is the number of pulmonary exacerbation per year. And you can see that it's from 2.5 to 3 pulmonary exacerbation per patient per year before ETI introduction. And it decreased to less than 1 pulmonary exacerbation per patient per year after ETI introduction. The third graph, 4C, is treatment load with from up to bottom mucolytic agents, inhaled corticosteroids, and then inhaled and oral antibiotics. And all of them are stable before ETI introduction, and you can see a frank decrease after ETI introduction. And the last graph is hospitalization for respiratory reasons. The line is the prevalence of patients being hospitalized during a year, and the boxes are the mean length of stay. So we had 45, then 47, then 56 patients hospitalized for respiratory reasons before ETI introduction, and this number drops to only 6 patients being hospitalized for respiratory reasons with treatment with ETI. And you can see that for hospitalized patients, the length of stay also decreases from around 20 days per year before ETI introduction to only 10 days after ETI introduction. So about our sputum cultures, a mean number of 4 sputum cultures per patient per year was collected before ETI introduction, and it decreased to 2.8 sputum cultures per patient per year after ETI introduction. And with this average number, you have to bear in mind that 18 of our patients did not produce any sputum cultures the year after because of lack of productive cough. So now back onto our main objective. Does ETI change the prevalence of CF pathogens and the overall density of lung bacteria? So this is our table of prevalences of microorganism for the 4 years. So the prevalences were very stable for each bacteria of interest during the 3 years before ETI, and this enabled us to use a mixed model comparing the year after ETI introduction to the 3 years before. On the last line, you can see that almost all of our patients was positive for at least 1 bacteria of interest during the 3 years before ETI. That's 99% of our patients, and it decreased to 161 patients, 90% after the year of ETI. So that was statistically significant. And now if we look at each bacteria of interest for Pseudomonas, the prevalence was around 70% of our patients, 140 patients, and it decreased to 105 patients, only 59% of our patients remaining positive. For methicillin-resistant Staphylococcus aureus, the prevalence was around 20 patients positive before ETI introduction, and it drops to 8 patients after, so that's a clearance in more than half of them. And we have similar results for Stenotrophomonas multifida, from 30 to 40 patients positive before to only 13 after. We also have very impressive results for non-tuberculous mycobacteria, from 14 to 20 patients positive before to only 3 patients remaining positive for non-tuberculous mycobacteria after ETI introduction. There was no significant change of prevalence for methicillin-susceptible Staphylococcus aureus, Haemophilus, Achromobacter, and Burkholderia sebaceous complex species. Now, if we look at the maximal density of bacteria in sputum cultures, you can also see that it was very stable for the 3 years before ETI, around 1.10 exponent 7 CFU per milliliter, and it decreased to 1.10 exponent 6 after ETI introduction. So we observed both a decrease in the prevalences of bacteria and in the density. So now, how does ETI affect Pseudomonas colonization? We wondered because it has such an impact on the respiratory symptoms of our patient and their morbidity and mortality. So this is a box plot about the evolution of colonization stages. The first box, light gray, is patient having never been colonized. The second box, dark gray, is intermittent colonization. The black box is chronic colonization, and the last gray box is patients considered as free. So if we focus on the last 2 years, we observed a 29% decrease of chronic colonization between the year before to the year after ETI introduction, and a 53% increase in patients considered as free. And intermittent colonization was very stable, and you can see that there is a slight decrease in patients never colonized, but that's because 3 of them did not produce any sputum cultures, and we had no primary colonization on the year with treatment with ETI. And so the last question is there a correlation between the clinical improvement we found and the decrease in lung colonization? So these are 3 graphs about the relative prevalence of colonization, and you can see it's grouped by year -2, year -1, year 0, and year +1. And the first, and it's regrouped with clinical features. So the first graph, 6A, is depending on the age range, and you can see that during the years, the decrease in colonization is stronger for younger patients, and that was statistically significant. So there was a correlation between the decrease of lung colonization and a younger age. The second graph, 6B, is still the percentage of patients being colonized, but depending on the percentage of predicted FEV1 at baseline at ETI introduction, from less than 30% to 20 to 50%, 50 to 70%, and more than 70%. And if you look at the graph, you get a sense that the higher the FEV1, the stronger the decrease, but that was not statistically significant. And on the graph 6C is the percentage of colonized patients depending on the improvement of FEV1. So if the change was between 0 and 15%, 15 and 20%, and 20 to 35%. And now looking at the graph, you can see that the decrease are very similar depending on the different ranges, and there was no correlation between decrease in colonization and improvement in percentage of predicted FEV1. So the decrease we found in CF pathogens is consistent with other studies, but the depth of the decrease may vary between studies. Because of the heterogeneity of the endpoints from 1 month, 3 months, 6 months, 12 months, and from the heterogeneity of the samples between sputum cultures, throat swabs, bronchoalveolar lavage. And because if our patient produced a positive sputum culture very shortly after ETI introduction, it was considered positive for the whole year, we might have underestimated the decrease in prevalence. But some studies found an early start to the decrease from 1 to 3 months after ETI initiation. So this underestimation of the decrease of the prevalence might not be that important. So our findings raise the question, how do we monitor non-productive patients? Do we use induced sputum cultures? At what frequency? And our findings on clinical improvement is corroborating data on clinical improvement. So we observed a decrease both in the overall quantity of bacteria and in the number of patients positive for most bacteria of interest. We found a decrease in chronic colonization with Pseudomonas aeruginosa, and we found no significant correlation between bacterial clearance and lung function, neither lung function at baseline nor improvement of lung function. and further studies are needed to better understand the mechanism of bacterial adaptation and resistance, and our findings are of interest to address the issue of antibiotic discontinuation. Thank you for your attention, and well, if you have questions, I'm more than happy to answer.
Thank you for that. That was a great talk. Any questions from the audience? There is, I think, a microphone in this room. I'm not sure if there's microphones in the overflow room. So feel free to come in if you have questions.
I just have one question, if you don't mind. Do you have any data about how many of those patients have bronchiectasis before starting their Trikafta?
No, we don't have data on how many patients have bronchiectasis. We have data on their FEV1, which reflects obstructive ventilation defect, but not on CT scans.
You may want to repeat the question. I'm wondering about any lavage microbiome or culturing work and complements.
Yeah. Oh, I can repeat it if you'd like. So you were just asking about microbiomic work on the sample, on the lavage samples for these.
Well,
Other samples just to complement.
yeah, we have no lavage samples. We have only sputum cultures, and none of our patients had any bronchoscopy during the year after ETI introduction, mostly because bronchoscopy are done before lung transplants, for example, and there was no need to do any for our patients.
And you may have missed this if you said it, but did this overlap the initiation of Trikafta with the COVID pandemic? And could you postulate
Yeah.
how that may have influenced your data?
Well,
Sure.
oh,
Just
sorry.
Repeat the question, I guess, for the people that aren't in the room. So the question was, did this study overlap with the COVID-19 pandemic, and how do you think that that may have influenced the results that you've got?
Yeah, that's a very good question. Thank you very much. Actually, it overlapped only for the people who had Trikafta before FDA approval. And the results are similar for this group, and which is about a 38 patient group, and the 150 other patients. So the results are similar. So I don't think COVID impacted that. The only impacts of COVID we could have thought might have occurred is the decrease in sputum cultures before ETI introduction, but there is still a huge difference between the decrease. Maybe I can show you the numbers of the sputum cultures. So you see, I think the year before, the 3.9 might be because of COVID. But the year of introduction, because we wanted to have sputum cultures for every people who started ETI, the number is higher, and it decreased more with ETI than with COVID. So I think that might be the impact.
I just have a question. I actually put it online. I wasn't sure what you guys were using, but like, how much do you think sampling bias reflects what your findings are because of this table that you're showing here? If they're not able to produce sputum, you're not able to detect the pathogen. How much do you think that this is influencing, and how do you account for that in your findings?
Well, we only had 18.
Yeah. So just for the people that aren't in the room, the question was about sampling bias. So given that there are fewer people productive of sputum, how do you know that your results are not reflective of sampling bias? Was that basically your question?
Like, how much does this influence your findings?
Yeah. How much is that influencing the findings?
Yeah. Well, we our population is 198 patients, and only 18 of them did not produce any sputum cultures, and 16 of them because of lack of productive cough, and 2 of them because moving out of the region. And so the number of patients not producing any sputum cultures at all is small, and also they have been they're not counted on the year after ETI. We based our percentages only on people who produced sputum cultures. So the decrease of prevalence is accounting those people who did not produce any sputum cultures. But also, we cheated a little bit, and we went to see if they produced any sputum cultures on the second year, and 9 of them produced sputum cultures the year after, and 7 of them still did not produce any sputum cultures. And well, 9 is a very small sample, but on the 9 patients, there was like clearance in 4 of them, and 5 of them had either less or the same colonization as the year before ETI introduction.
Maybe just a technical question. So have you checked the quality of sputum? So is it
Yes.
Is it sputum?
Yes, it is sputum. Sorry.
I'll just repeat that. So did you check the quality of this? Is it actually sputum that you were getting from the patients?
Yes, it is. We only selected sputum that met the quality in terms of number of lymphocytes and epithelial cells, so we know it's sputum.
Before you go, I just want to make a quick comment. We're not seeing the questions online, so if you put one there, apologies, but feel free to reach out.
It's showing up now. It wasn't showing up before.
Okay, maybe it's showing up now.
But yeah, we had checked before and nothing was there. So, yeah.
Thank you for your talk. My question is related to absolute abundances versus just the relative abundances. So how do the absolute abundances of each of these microbes change pre versus post ETI? Like, are we seeing a big reduction in the absolute abundance of each of them there as well, or is it just more of a relative abundance changing?
We tried to assess the. I have a slide for that. We tried to assess the absolute abundance with this graph, but it was not shown in my presentation because, as you can see, the numbers were not stable for the 3 years before ETI. So it's probably due to confounding factors. So I don't know if we can, interpret this with strong confidence, but if you look at this, you have a decrease that started before ETI introduction for most of the bacteria of interest, but at ETI introduction, all of them decrease, but Haemophilus influenzae, and it has a absolute abundance that is increasing. And I think that might be good news because Haemophilus influenzae is a very fragile bacteria. So if its abundance is increasing, it might indicate that the other bacteria are really decreasing. The other CF pathogens are really decreasing.
Thank you.
You're welcome.
I just had a final question, if I might. I'm wondering if you're continuing to follow this population group, because I'm particularly interested in your opinion about what will happen at year +2 and year +3.
Yeah.
There's some interesting data coming out about a sort of rebound effect.
Yeah.
Just wanted to get your impression on that.
Well, we're still following them. Clinically, their respiratory state is stable, and we don't have an increase in hospitalization or pulmonary exacerbation. And on bacteriological data, we don't have all the numbers because they reached the 2 years endpoint in October, November, so we don't have any data to show about that.
Okay. Thank you.
Thank you for that great presentation.
Yeah.
Thanks, sorry. Next, we'd like to welcome up Dr. Sarah Watchell to present her talk on utility of bacterial swab cultures in adults with CF.
Hello, I'm Sarah. I'm joining us from the University of Vermont up in Burlington. Okay, so I'll be talking about the utility of bacterial swab cultures in adults with cystic fibrosis, and I feel like this is just such a great thing to come after what we just heard, because it really just kind of seems to continue the story. The other folks who worked on my presentation with me, Bradley Tompkins, who did the statistical work, and then Dr. Tenebach is my research mentor for this project. How do I go forward? Not the arrow? Not the arrow. Clicking. Maybe clicking? Hey, there we go. Okay. In our clinic, I think this is pretty universal up in Burlington, we get routine quarterly sputum cultures on our cystic fibrosis patients. For those who can't produce sputum, we've been getting throat swabs on these people. Dr. Tenebach and the other CF providers in our clinic were kind of just anecdotally feeling like after starting ETI, fewer people with CF were actually able to produce sputum. So, and clearly other people are seeing the same thing. They also were seeing anecdotally that they were feeling the throat swabs were less likely to be positive for CF pathogens when compared with the traditional sputum cultures. And so this was a project to pretty much just quantify and find out if that was really true or not. So what we did, we used both Port CF and medical record data in this project. Amazingly, Port CF had dates of cultures. They had what pathogens, if any, grew on those cultures. And so I did not have to do as much epic digging as one might assume, which was great. What Port CF did not have was the type of sample, whether it was a sputum or a swab. So that was pretty much what I went digging for. Luckily or unluckily, our clinic is not huge. We don't have the biggest population. We have 85 adult patients in our CF clinic. It's a lot of northern New York State, and Vermont is kind of our catchment area. And overall, we had 1,162 samples to look at. We used very similar kind of time frame to the last project we heard about. So 2018 to 2022, we were trying to get 2 years before and 2 years after ETI. We looked at the data from both sputum cultures and throat swabs, and we defined positive cultures as those that yielded a known CF pathogen, such as Pseudomonas aeruginosa or Staphylococcus aureus, and we used a fixed logistic regression model to analyze these samples. So some of our exclusion-inclusion stuff, we started with those 1162 cultures and from 85 patients. We had to exclude 3 patients because we couldn't quite figure out when they started ETI. One patient did not stay on ETI. He was excluded as well. 96 records, we couldn't quite figure out if it was a swab or a sputum sample. Some patients get their cultures done at a different institution that's closer to home, or they visit quaternary centers, and we couldn't get the data from those. So really only the ones that were done at UVM we were able to actually figure out whether it was a sputum or a swab. 19 of the records were BAL samples. Those were excluded. 14 patients never started ETI. They were excluded. The statistical analysis that was used, we needed 2 specimens, so 25 patients were excluded for only ever giving us 1 culture. So we ended up with 607 records from 41 patients. And here is the kind of descriptive characteristics of our patients. So we had 41 patients. The mean age was about 35. We were about 50% female and 50% male. We were 100% Caucasian. BMI mean was 25.2. Their FEV1 mean was 82.6. And then for their CFTR mutations, 22 of them, or 54-ish%, were homozygous for Delta F508, and then 39 were heterozygous. So our first question, compared to a baseline prior to ETI, people with CF who are now on ETI are less likely to expectorate sputum for bacterial culture. And this was very significant. So the p-value on this was less than 0.001. We decided, clearly, yes, they are. We're getting fewer actual sputum cultures and more people who can't produce sputum after ETI. So then we got into the questions that we actually thought were kind of not just confirmatory and like real questions. So in people with CF on ETI, bacterial cultures obtained by throat swab are less likely to yield a positive culture result than those obtained by expectorated sputum. And this was not positive at all. You can see, it crosses 1. So basically, we did not confirm that was true, and we did have to exclude a couple more patients who only provided one specimen for this culture. So we ended up with 189 observations from 30 patients. We had a couple other questions that we wanted to ask as well. So, is there a difference in yield of throat swabs obtained during an exacerbation compared to routine follow-up? We have a lot of patients who come into the hospital and are able to produce sputum at that time. And we were curious if those samples kind of changed compared to the routine cultures that we were getting at clinic visits. And that was also not significant either. So that question also was not significant. And again, we ended up excluding a couple patients. We had 6 records where we couldn't figure out what their exacerbation status was, and again, excluded patients with only one sample. So for this graph, we only have 237 records from 31 patients. And lastly, is there a difference in yield of throat swabs depending on prior bacterial cultures? And again, this one was not significant at all. And we did have to exclude some other patients as well. So in this, we ended up with 48 patients in our group. So overall, this project confirmed a statistically significant 87% reduction in odds of providing a sputum sample after starting ETI with a very significant p-value. There was, however, no significant difference in the odds of having a positive specimen between throat swabs and sputum cultures. And that was really our main question that we wanted to answer. And this was an exciting project, I think, for our department because it really could have changed management of these patients, and actually it confirmed our current management. So that was really great information to have. And then as our exploratory questions, we saw no significant difference in the odds of providing a positive specimen during an exacerbation or depending on prior bacterial cultures. So in conclusion, throat swabs are non-inferior to sputum cultures for obtaining a microbiological diagnosis in people with CF on ETI or HEMT. Some limitations of our study. It's a pretty small sample size. So we only started with 85 patients in our adult clinic up in Vermont. And as you saw, we had to exclude a lot and ended up with really pretty small sample sizes. So that, I think, was our biggest kind of limitation of this study. Yeah. That's the end.
Okay, I can see we've already got some questions from the floor. Do you want to maybe, just for ease, it might be. Thank you.
Thank you for the great presentation. My question is around what you might have been able to see in those sputum cultures and throat swabs. I mean, are you seeing concordance with the type of bug? For example, if there was a positive Pseudomonas culture, were you also seeing it in the throat swab, staph, and all that? Was it just overall positivity? Sorry, I didn't.
It was, for this study, it was overall positivity. It was like if you grew any bug, that was positive. So we didn't specifically look at the types of bugs or concordance between.
Are you going to?
That's a great question. Hey, Dr. Tenneback, where are you?
Thank you.
I think it's a great idea. I think we'll be limited by the numbers.
Yeah. Yeah.
Any other questions?
Hi there, thank you for your talk. Do you think that there could have been any issues as far as the throat swab technique used as far, between patients, whether there was a physician or the person that was collecting maybe was better at collecting it versus potentially not?
So it's always possible, but I think that that's kind of inherent in throat swabs, right? And so I think that, I don't want to say it doesn't really matter, but I think when you're looking at a throat swab, that's kind of always in there. And so I don't know that it really makes a big difference. Yeah.
I just have, I suppose, a comment because I think both, I'm not mistaken in thinking that you're also in pediatrics, Dr. Gross, right? So we haven't had, I think in a lot of cases, the luxury of having sputum samples. So I think for the adult population, this is somewhat new territory, but for us, this is sort of like accepted practice. But I think I guess just want to caution on maybe being too liberal with the conclusions, because there are a number of like quite large studies that have looked at paired sputum inductions. Like I think the CF spit sample CF spit study most recently in Australia, it was with children, I think, but they looked at induced sputum, bronchoalveolar lavage, and throat swabs, and they did find that there was, I think, with enough patients, there is a difference in what you'll find. Like lower airway specimens are better if you can get them, but relying on throat swabs, I think if you need to is acceptable.
And I think the enough patients is the key. Yeah.
Let's see, I have a question, kind of follow on to that. I know this was retrospective, but are you now trying to use more induced sputums to collect samples compared to before?
Are we?
We're finding a lot of reluctance in folks doing induced sputum via prescribed, particularly people growing and they haven't had good luck actually. So I think a few people have tried to not be able to produce anything, and overall it's hard to convince our adults to use sputum.
Yeah, so just to repeat that answer, the answer was generally that it's been difficult to convince the patients in this population to do induced sputums, and so they have not been as successful as maybe they would like to be.
I think that maybe means that as pediatricians, we need to introduce it earlier so that they're used to it by the time they get to adult services.
Any last questions? And again, we are not seeing anything online, so now is your chance. Okay, thank you then.
Thank you.
So next we would like to welcome Dr. Gina Hong, who will be speaking to us about home collected sputum samples for Aspergillus fumigatus detection in adults with CF.
Thank you. Just gonna try to see if I can grab a laser pointer just in case. They showed me in the speaker room here. Okay, just so they could see. Good morning, everyone. Thanks to the organizers for inviting us to share some of our preliminary findings from a pilot study that we had conducted. And it's not letting me advance. Okay, there it goes. I have no relevant disclosures. I think we've already discussed a lot of this already, but I just want to highlight we have all observed a shift in infection surveillance and detection in people with CF in the past 3 or 4 years. And I would say this is largely due to 2 main contributing factors, one being ETI, which we've already discussed. So in addition to the clinical respiratory improvements that we've observed in our patients, we do know that the sputum viscoelastic properties and inflammation have changed pre and post ETI, and also we have observed changes in sputum volume and the frequency of expectoration. I mean, that's why we're having this workshop here today. But then the second contributing factor is also the COVID-19 pandemic, where there's essentially been universal population infection control practices with increased masking in the general population. Then also it kind of catapulted us into this sphere where we were implementing more telehealth usage in the CF clinic space. And so as a result, we see less sputum for infection detection in clinic. And I would argue from some of the early findings from the PROMISE study that in individuals with known chronic bacterial infection, it often persists even post-ETI, although the densities may be different, as the speaker alluded to earlier. So I would say that approaches to detect and diagnose infection are still necessary in our population. And so the CF Foundation conducted a survey through Community Voice, which this was quite some time ago, it was in 2021, where they did observe that about 60% of individuals were still coughing up sputum at home, even though we were seeing a greater proportion of non-expectoration within the clinic. And so these data suggested to our group that there may be opportunities to remotely sample sputum from people with CF despite them just having a dry cough in clinic. And so sputum sampling is really critical for our research program because we're really interested in Aspergillus fumigatus. And for those who don't know, fungus cultures are really not routinely performed on oropharyngeal sampling and really require sputum or BAL fluid. And so since Aspergillus fumigatus exhibits properties that make it very hardy, we also hypothesize that it would likely survive something like overnight shipping and ambient temperatures. So this led to us devising a pilot study. This was prospective, which was aimed to test the feasibility of home sputum collection and ambient transport for the detection of Aspergillus fumigatus in adults with CF. So I know this figure looks a little bit busy, so I'll try to guide you with a laser pointer, but this illustrates our study design. So Penn enrolled adults with CF, 18 years and older, without a history of solid organ transplantation in this fully decentralized study. So this means that nobody had face-to-face time in clinic. It was all remote. And so we received also referrals from National Jewish Health, University of Washington, and Johns Hopkins, and that was really to diversify the geographic representation of the population. And we had targeted an enriched population of people with a history of Aspergillus fumigatus. And this was largely because of our secondary objective, which was to test various microbiologic culture conditions to devise an ideal culture study protocol to detect Aspergillus fumigatus when present for future clinical trials. But I will say that after our interim analysis, you'll see the second bullet point that we also expanded our eligibility criteria to enroll some individuals in a second cohort without known history of Aspergillus positivity. So once we enrolled the subjects, we actually equipped them with the training and the materials for remote sputum collection, and those adults who were enrolled directly shipped them to our collaborating laboratories. We used FedEx as our transport mechanism, and they sent them directly to Dartmouth laboratory that was led by Rob Kramer, that's depicted over here with his lab team, and Johns Hopkins, led by Sean Zhang. And so what we instructed our participants to do is that they would collect it at home or whatever remote space that they wanted to. And they were asked to ship one sample per week for 4 separate occurrences. So keep in mind, there's repeated measurements from a single participant. And they completed these electronic questionnaires, which really gathered their real-time experience because this was important for us to understand. So once the specimens were received by the laboratory, the sputa were tested in various culture conditions for Aspergillus growth, which I'll explain a little bit further in the future slides. So we began the study in October 2021. We completed it in July 2023. We enrolled 76 adults with CF. The map over here just shows the representation of where the participants were from. You could see that it's dominated from the East Coast, but I would say that we were well represented in the other regions as well. So amongst the 76 enrolled, 2 subjects were unable to successfully send in any samples, but you could see a total of 287 samples were sent by our participants. 3 of which were lost via FedEx. And I will say that this is pretty successful because this was also during the pandemic and also holiday season in the United States. So I would say that that's like a positive. So 284 samples were received. 281 samples were analyzed because 3 of them were insufficient quality, mostly related to undetectable volume. And you'll see the transport time that's summarized on that bottom there, where the average transport time was 7 days. We did this via overnight shipping, but you could see that the range was from 1 to 9 days. But I think that this highlights overall successful shipping and receipt of these samples. So this was our cohort characteristics. We had 76 participants, most of whom were older adults because the median age is 36 years. And I just want to highlight here that 80% of individuals were on highly effective modulator therapy or HEMT, which in our study, just to make sure that I'm highlighting this compared to the previous abstract, we actually defined HEMT as both ETI and ivacaftor, but you could see the majority of individuals are on ETI. And there are 58% of people with Aspergillus fumigatus history in our cohort. So our primary outcome was feasibility for this pilot, and we wanted to look at the proportion of subjects successfully collecting and sending in 3 or more sputum samples. So again, there were 284 samples that were received, and amongst the 74 participants who successfully submitted samples, you could see here on this figure that 88% gave us all the samples that we asked for, 4 or more, with really a small proportion not able to collect any. And based on our questionnaire data, which we collected at each sample collection, that 91% of these sputum collections were done during stable pulmonary health. So this was not that they were producing samples because they were just sick. So the most common method used to collect home sputum was actually nothing at all. They were reporting that they were collecting it spontaneously. This was up to 47% of these collections. But the remainder of individuals used some form of airway clearance medications or methods to collect their sputum. So it was really important for us to understand the patient experience. Like, would this be something that would be positive on their end? And we collected these data via questionnaires. And we found, when asking how easy it was for the participant to cough up the sputum sample, that 29% of individuals, 29% of collections were easy, 40% were somewhat easy, and about a quarter being difficult. When we stratified this by HEMT use, again, this is ETI and ivacaftor, which is really indicated in that dark blue, we see that still it's fairly easy for these individuals to produce sputum, but it is certainly more difficult compared to those who are not on HEMT. And in regards to sputum transport, when asked how easy was it for them to send the sputum to the laboratory, most participants reported that this was easy or somewhat easy and very rarely difficult. So we conducted questionnaires and interviews with the participants at the completion of the study, and the response was really overall positive. So all participants agree with the following statement: home sputum collection is a great method to test my sputum for clinic and research studies. And some of the verbal and written feedback that were received from the participants are listed here. I mean, the themes were that this was simple, straightforward, easy to follow. I mean, one participant even said, I hope that this can become a standard for collecting sputum. And you could read the remaining kind of quotes from our participants. And I think this really just highlights that we can collect home sputum, and this is favorable from the patient perspective. Now let's switch gears to share some of the early laboratory data. So we had 281 samples that are adequate for analysis. This is, again, 74 unique participants. And this dot plot over here to the left kind of illustrates the distribution of the sputum volume. And I think that this is really critical for us to understand. So each dot represents a single sputum. The volume is on the y-axis, and that's the units are milliliters. And we see that the average sputum volume, which is indicated in the red, is only 2.75 mLs. And that's about equivalent to half a teaspoon. So this is very small volumes compared to what we've observed prior to ETI. And when we break it down between, or stratify between hemp usage, we found that the mean volume is slightly greater than those not on hemp compared to those who are on hemp. And we actually conducted generalized estimated equation models to account for subject correlation and repeated measurements to examine the independent relationship between ETI and sputum, and we find, or sputum volume, excuse me, and we find that ETI, unsurprisingly, is associated with the 0.75 ml lower sputum volume compared to those without ETI. And so we also wanted to measure sputum quality. This was kind of asked in one of the questions before. Are we collecting sputum from them? And so we actually measured this more of a qualitative kind of approach. And so we observed amongst 281 samples that 43% of our sputum samples were mucus in nature, 28% were semi-mucus, and 29% non-mucus. And you could kind of see from here, this is that mucus sputum that we're all kind of used to. And this is the non-mucus sample, which may be of lower quality. And we did also explore whether or not ETI was associated with this mucus texture quality, and we did not find any significant associations. So to identify the ideal culture conditions to detect aspergillus when present in CF sputa, we sought to test various culture conditions with each sample. And so this included sputum processing, really through mucolytics such as DTT, ultrasonication, various culture media, incubation temperatures, and also oxygen and carbon dioxide conditions within the incubators. And we also accounted for sputum volume because there's existing data to demonstrate that sputum volume may, the greater the sputum volume, the greater likelihood of aspergillus positivity when present. I do want to highlight that, so our samples, I should have mentioned this in the schematic before, but our samples, there were 4 collections from each participant, and collections 1 and 3 went to the Dartmouth lab. Collections 2 and 4 went to the Hopkins lab. So this was not that a single sample went to both laboratories. And so each laboratory, because this was a pilot study, was individually equipped to conduct their study. So the variables that are bolded in this table are the ones that were conducted by both laboratories. Ultrasonication, 30 degrees Celsius for incubation temperature, and also ambient CO2 within the incubators were only tested in the clinical laboratory at Hopkins. And so because of these differences, we actually present the data stratified by laboratory. So we found a high proportion of aspergillus positive cultures. This was actually surprisingly higher than we had initially hypothesized. Each lab actually showed about 70% of the samples received being positive for aspergillus fumigatus, and an overall prevalence. So this is when you're looking at the unique participants as a denominator, there were 95% of prevalence. And keep in mind, this is not of the general CF population. This is an enriched population that we specifically wanted to see, we sought out because of their history of aspergillus. So the overall conclusion here is that we could find aspergillus in home sputum sample collections in adults with CF. So I'm going to lead you through a couple of busy slides, and I'll try to highlight this at the end because the laboratory data, we are comparing multiple conditions, and I'm breaking it down between Hopkins and Dartmouth Laboratory. I'm going to kind of go quickly because I'm running out of time here. So amongst 163 samples that were collected by the Hopkins Laboratory, when looking at sputum processing, again, that's mucolytic and ultrasonication, we saw no association with sputum processing and aspergillus fumigatus positivity in our generalized estimating equations that were really employed because we had multiple comparisons. Sorry, Jane, can I keep on going? All right, multiple comparisons and repeated measures from unique participants. So the things that I want to highlight is that with the Chepex Dox agar, which is a nitrate-containing non-selective media, we saw a significantly decreased odds for aspergillus fumigatus positivity compared to the inhibitory mold agar, which was our reference. We also did see that 30 degrees Celsius in normoxia, which is like the standard, was associated with a decreased odds in, standard normoxia being the standard, not the 30 degrees, but was associated with a decreased odds in Aspergillus fumigatus positivity compared to 37 degrees, suggesting that really body temperature is better. And then 37 degrees Celsius in hypoxia was actually associated with an increased odds for Aspergillus fumigatus positivity compared to the reference. And of note, we looked at that in both a CO2 enriched and non-CO2 enriched. And so this was only in the setting of without 5% CO2. When looking at the Dartmouth data, so a little bit lower samples, but 117 samples, we actually did not see differences in the incubation conditions, but we did see a statistical interaction between incubation condition and sputum processing. So when we look at just mucolysis within hypoxic conditions alone, we see that mucolysis has a lower odds of Aspergillus fumigatus positivity. So we did not observe the same relationships between the CHEP-X docs and the Aspergillus fumigatus detection in the Dartmouth lab as we had seen in the Hopkins laboratory, but we did see a statistically significant association between Sabarog with gentamicin being associated with the 23% lower odds of A fumigatus positivity compared to the inhibitory mold. So really quick, taken together, I think some of the early observations that still need to be hashed out here are that body temperature is better than 30 degrees Celsius for fungus cultures to recover Aspergillus in CF sputa. Hypoxic conditions may be associated with an increased odds for A fumigatus, and this is again without CO2 enrichment. And that inhibitory mold agar may be the ideal culture media for our future clinical trials if we were to implement this study protocol. So in conclusion of the entire presentation, we think that home sputum collection is feasible, and this is in adults with CF on ETI, and can be a potential option in this era where we're having difficulty collecting sputum and trying to perform surveillance and detection in people with CF. I will say, though, that these are very small volumes, so that must be taken into account in how we interpret these data. And that Aspergillus fumigatus can be detected in home-collected sputa. And then finally, that inhibitory mold agar in 37 degrees Celsius may incur the best odds for Aspergillus detection when present. I will say is that we were not, this is a limited study. We were not equipped to validate this. We did not have any in-clinic sputa to compare in these participants. We only had past culture data. So really validation for how we can use home collected sputa is required to better understand how this can be implemented potentially in research or in clinic. And of course, there's a whole body of people who are behind this. So thanks to everybody. I want to give a shout out to Annie, who is in the audience. She was our clinical research coordinator that really coordinated a lot of this work. Thank you so much. And thank you to the moderators for letting me go over time.
So we have about 4 minutes for questions, but please, yes, bring your questions.
Very nice presentation. Who paid for the FedEx? And was this
the CF Foundation? It was the funding. So we did. So it was not by the. So this was a fully funded research study. The CF Foundation were the sponsors. So we had generated prepaid mailers and gave them all the equipment. That's why it was so easy. It was down to the Sharpie where they could label their specimen. We provided all those materials. So it was the research study who covered the FedEx costs.
And this is off track. What did you do with your positive specimens? Are you going to treat all those positive Aspergillus? Or?
No, we are not. No, no. So this with our findings, it's actually not even. This is ultimately why we had done the study, because we want to better understand what the clinical implications and the impact of Aspergillus fumigatus in people with CF. So no, we did not treat. Yep. So the question was, were there instances where there were shipment beyond the 24 hours, and did we exclude them from the analysis? So yes, there were instances. So the range of what the shipment, when the shipment was sent off by the participant and when it was received, ranged from 1 to 9. But the mean was only about 1.3 days. Really, the overwhelming majority, over 90% of our samples were within 24 hours. The people who ranged in that larger range, they were still included in the analysis. I will say is that there is one sputum, unfortunately, that is in that range where we could not analyze because the laboratory really felt that it was not a specimen that was essentially the description for the laboratory, that it was hot and very discolored. They felt like it would be inaccurate. So that was really the only one that was not analyzed for the comparisons of laboratory conditions. But really all the others, even outside of that 24-hour range, were included.
Do you plan to do induced sputum at home?
So that's an interesting question. When you look, I'm sorry. The question was, do you plan to do induced sputum at home? So it's interesting because we actually allowed the participants for this study to be flexible of how they want to produce their sputum. But there are, I know, certain institutions that are trying to explore that. For example, like Julian Fortin's group, who are trying to do this within the pediatric population. That is not something that we future plan, but if one were to devise a research protocol, you can consider making it more standardized and administering the hypertonic. I will say, because of the Simplify study results, though, a lot of patients don't even have hypertonic at home anymore. So, it will get to be determined, but our group does not plan to do that. Another question.
Were there many temperature extremes with this study that might have impacted the viability of the organisms?
So we are unable to measure those temperature extremes. I think that the question is very valid, though, because as you could see, the duration, it encompassed almost 2 years. So that included very hot conditions and very cold conditions. So I think those extremes are real. Whether or not that they contributed to why we saw so much fungus, because as we all know in this room that there's fungal spores everywhere, we are not able to measure or account for that. But my guess is that I think certainly that that was present, and that may be impacting how we interpret our findings.
All right, one last question. Thank you.
I wonder if you plan to check the sputum samples for the presence of other CF pathogens other than Aspergillus, which are probably even more.
Thank you for that question. I included an extra slide just in case, but I probably don't have time. So towards the end of our pilot, especially because if anybody, studies Pseudomonas or studies Aspergillus, is that obviously that there's a lot of interactions between these microbes that may account for why you grow and why you don't grow. So yes, we explored that. I don't know if I'm allowed to show that slide. So amongst 15 of our participants, we actually, if they had residual samples, we plated them on bacterial culture media. And the bottom line is that we're growing CF pathogens. However, if you look at the figure or the table on the bottom, so keep in mind, we don't have paired in-clinic samples real time because this was fully decentralized, but we compared it to their old culture history, which we did capture. And the kappa statistic for the concordance of Pseudomonas is moderate. It's 0.49, and that was statistically significant. So it suggests that other CF bacterial pathogens can potentially be recovered in home-collected sputa. But again, if you look at, for example, staph there, the concordance with historical culture data was very poor. So, I need somebody to sponsor that grant, but I think that that's really what we need to do here, aside from just Aspergillus. All right.
Thank you so much. I'd like to welcome up, it's a good time to welcome up the next speaker, Dr. Pavel Drevenek, who's coming to us from Motol University Hospital. and he's going to be presenting about detection of Pseudomonas aeruginosa infection using antibodies against lipopolysaccharide and exotoxin A.
Good morning. Thank you very much for giving me the opportunity to share with you the data on the use of serology in the clinical practice. So this is how to there. Okay, so this is our disclosure slide. So one of the authors was the former employee of one of the biotechnology companies, which produces the kits for detection of the antibodies against Pseudomonas aeruginosa. So let me start with the reminding how's the clinical or how's the natural course of the Pseudomonas aeruginosa infection, where there are two basic stages described. One of them is the new infection, and then it goes to and it turns to be the chronic infection if there is no intervention. So the clinical response to those phases of infection are very different. So we try to eradicate the Pseudomonas aeruginosa at the beginning of infection, and if we are not successful, then we use the suppressive antibiotics or we treat the acute exacerbations. So we need not to miss the opportunity to eradicate the Pseudomonas aeruginosa at the very beginning of the infection. And for that reason, we need a very reliable microbiological tool to be able to detect Pseudomonas aeruginosa as early as possible. So we know that there is the array of possibilities how to detect Pseudomonas. The right column says that there are direct detection methods which can be used, like culture-based detection, species-specific PCRs, or more research-based next-generation sequencing. And these all detection methods can be applied to the airway samples. The easiest airway sample to collect is, of course, the swab, oropharyngeal or throat swab or cough swabs. But we all know that there are the clear limitations of detection from this sort of sample because of the problematic sensitivity and also the specificity. The other samples which are representatives of lower airways, like sputum or induced sputum on bronchoalveolar lavage, are good samples, but there are some inherent limitations. Some of them are there is some invasion to get the sample, or in context of sputum, we already heard about that. There is no longer available sputum from many patients on high effective modulators therapy. So we search for alternatives, and there is one of the very interesting areas of exploration, which is the exhaled breath, and we will definitely, I'm sure, hear more during the next presentation. Urine samples, where we can try to detect some of the metabolites of bacteria. So these are, but these sort of samples are they are experimental. And there is another sample, and that's a serum, and this is nothing new. Serum sample which we can be used for indirect detection of Pseudomonas aeruginosa. I said it's nothing new, it's not a novel concept. Serology is being used for years in the CF microbiology, and the term of serology is used, for instance, for one of the definitions of chronic infections. This is the example from the European registry data that the variable of chronic infection is defined either through the multiple positivity by culture or through raised antibodies levels in serum sample. The definition or the use of the term of serology is also used for the definition of the new infection. And this is one of my favorite definitions for the new infection of Pseudomonas aeruginosa, which says that the new infection is when you detect Pseudomonas aeruginosa for the first time, and it's accompanied with the anti-Pseudomonas aeruginosa antibodies levels, which are below the cutoff for chronic infection. So we started to do the detection of the antibodies in our patient cohort, and we worked with 3 different commercial kits which are available. One of them is the kit which includes 64 different antigens of Pseudomonas aeruginosa. So these antigens were taken from the whole cell extracts. Another kit is focusing on 3 virulence factors of Pseudomonas aeruginosa: exotoxin A, elastase, and alkaline phosphatase. And the third in a row kit is focusing on lipopolysaccharide and of one of the virulence factors on exotoxin A. So the data which I will show to you are the data where we measured the antibodies via the use of the kit anti-Pseudomonas aeruginosa IgG, lipopolysaccharide, and exotoxin A. So this is the prospective study. Actually, this is our now routine practice that we check the antibodies titers in patients with cystic fibrosis. So from January 2022, we collected over 600 serum samples from nearly 400 patients, and some of the patients provided several samples over this time period. The infection status was characterized for the majority of our patient population. We use the Leeds criteria, but I have to say that this is up to the discretion of the physician. So they say if the patient is chronically infected or intermittently infected, or it's free of infection, or it's been never infected with Pseudomonas aeruginosa. So because we had this data, we could allocate the serum samples to those infection status to those patients. So what you can see that majority of samples were allocated to patients who were either free of infection or never infected according to the Leeds criteria. So the table summarizes the data. So the most of cases we could measure the antibodies and say that there is the antibodies positive serum sample or antibodies negative. Around 5% of samples were the borderline, so where we were not absolutely sure if it's positive or negative. It's always the case in laboratory that some samples are borderline. But interestingly, and a good sign was that we had a very high concordance between the positivity status and the chronic infection status. So that's what one would expect, that if you have a chronically infected patient, you should measure some antibodies in the serum. So 95% of serum samples from chronically infected patients were positive for antibodies. But we had the concordance only 75% for the group of patients who were never infected, according to reports from the physician. So some 20% of patients were never infected, but actually had some positivity in serum. 77 serum samples were positive. And we could observe something similar, even higher proportion of positive serum samples in the group of patients who were free of infection. So we can already speculate why this happens. It could be true positivity, and then it would mean that the serum, the serology, the detection of antibodies, means early detection of the new infection or reinfection in cases of the free of infection status. Or it can be also false positivity. And we all know that antibodies persist in serum after infection is cleared. So let's have a closer look to these two infectious status categories. The first, infection status never. So as I said, there were 77 serum samples positive. They represent 53 patients out of the cohort 218 patients. So 24% of patients who are reported never, so should be without Pseudomonas aeruginosa infection, had a positive serum sample. So to better assess if this is true positivity or not, so we looked at other parameters. So we looked if we've got multiple serum samples from the same patient collected, and then also if there were multiple positivities per patient. And also to look if there were the microbiological findings from these classical culture-based or PCR-based methods, which were taken which were done in parallel or afterwards. So what we can observe that 7 patients had actually afterwards positive Pseudomonas aeruginosa by culture or by PCR, and 29 patients had positive serum samples in more than one situation. So there were serial positivities. So altogether, we can say that 17% of the patient population, 36 out of 218, had serum positivity repeated or accompanied with culture or PCR finding, which indicates that this serum positivity could definitely indicate the finding of Pseudomonas aeruginosa in lungs. So the infection status of free of infection. This is not the exact copy of what we've seen on a previous slide. There were also positive serum samples, 64 serum samples representing 49 patients out of the cohort. So 40% of patients reported to be free of infection had positive serum sample. But if you look again to more granular data, we can see that only 2 patients out of them had the positivity for Pseudomonas aeruginosa also by culture or by PCR. And the majority of these positive serum samples were found to be positive on multiple occasions, but it was only positivity for antibodies, not positivity by culture or by PCR. So 27% of patients who are called free of infection still have positive serology. So now I would show you 2 examples from the clinic showing the findings of Pseudomonas aeruginosa by various methods in 2 of our patients. One of them is a girl. She was born into 2021, and through the regular screening, she was negative during her first year of life. But in March 2023, we found positivity by PCR of her nasopharyngeal aspirate, and we also found the serology positivity. At the time, she manifested the pulmonary exacerbation, and then week after, when we repeated the culture from another nasopharyngeal aspirate and also from sputum sample, we found actually the positivity by culture. So the serum positivity, the antibodies finding was true positivity and was a good indicator to go further and to try to find the Pseudomonas aeruginosa by culture. Another example is a girl born in 2019, again negative for her first year of life, and then suddenly during the classical checkup, she was found positive by serology only. Her aspirate from nasopharynx was negative. So based on the serology, the clinician decided to go to undergo the bronchoscopy and check the bronchoalveolar lavage. And we found the Pseudomonas aeruginosa in bronchoalveolar lavage. So then the girl was treated anti-Pseudomonas with the anti-Pseudomonas regime. And still 1 year later, she was positive for her antibodies, and also positive from her sputum. Luckily, later on, this is like 1.5 years later, she was found negative from the check bronchoalveolar lavage. So in conclusion, what to say about the positive finding, positive antibodies against lipopolysaccharide and exotoxin A? So these are almost always found in serum samples from patients with chronic infection. So there was the concordance of 95%, which is good, and I would say this is quite reassuring that we can measure and find the antibodies in patients who are chronically infected. But we also found serum positivity in 17% of patients with status never, and that's something worthy of considering that it could be true positivity. And remember that in many situations we are now dependent on culture results from samples which are not representative of airways. The most of cases are the swabs, so we have only swabs, and we know that swabs can miss Pseudomonas aeruginosa. And I should also say that for the group of patients who are free of infection, so treated successfully, so who cleared Pseudomonas aeruginosa, we see quite a number of patients positive for antibodies against Pseudomonas aeruginosa, and that's really difficult to interpret. Does this mean the persistence, or does this mean something like reinfection with Pseudomonas aeruginosa? We just don't know. So what I want to highlight is that serology is just another piece of the puzzle, and we need to use it in combination with culture, with PCR, and also, of course, with the patient history, so assessment of the patient status, to say if patient is actually infected with Pseudomonas aeruginosa or not. Thank you very much for your attention.
Okay, great. Thank you so much for an amazing presentation. I think we've got a question right off the bat.
Hi, I'm Catherine Armbruster from Dartmouth. I was wondering, for the folks that don't have Pseudomonas in their sputum cultures yet are antibody positive, do you know if they have CF sinus disease? We know that Pseudomonas can be in the sinuses.
I don't have the data right now, so that definitely could be one of the explanations, that the Pseudomonas can be somewhere outside lungs. Yeah.
Thank you.
So do you know the specificity of this serologic assay? Is there any cross-reactivity with other gram-negatives?
Yeah, so we checked that, at the beginning before we started to use that. So for the cross-reactivity, we haven't seen any cross-reactivity with the common pathogens. We found with another Pseudomonas, and I can't now remember the species name. So one Pseudomonas, there was a cross-reactivity, and we see in one patient who is chronically infected with that Pseudomonas positivity for the antibodies. So there is definitely, and we know that in general for serology that specificity might be the issue. Yeah, you are right.
Do you know anything about the class antibody subclasses or IgG subclasses?
Yeah, so if we know about the subclasses of the IgG, or so which isotopes we actually measure. So this is IgG. I can't say, I can't be more specific. I don't know.
I was wondering if you detected in the special patient population positive for serology, but the cultures were negative. It obviously means that the bacterium detection method is not sensitive enough. They must have had Pseudomonas. So is that a concern that the antibody detection is more sensitive than the bacterium itself, or the bacterium had to be there if you have IgG already, if we believe those are reasons.
I wouldn't dare to say that serology is better than the culture or something like that. So what I said at the conclusion, the trouble is that now we don't have the best possible samples from airway. So we are now very dependent on the samples like these cough swabs, throat swabs, which are, better than nothing, but we must be very careful about the interpretation. So that's why we now started to use the serology, especially for the group of children or patients who don't expectorate sputum, to be a little bit, on more safe side, So it's like just another indicator if the infection can be there or not. So we combine the data from culture with the data from serology.
Intermittent infections cleared, and then you get positivity, and that could be picking up.
Yeah. So the question is about if serology findings are delayed in terms of the course of the Pseudomonas aeruginosa infection. It depends on the kit. Some of the so when you look at the literature data, some studies use the serology for confirmation of the chronic status. So they counted on that there is a delay. But the other data can show that it can be used for the new detection. We are not completely sure if it's not still delayed, but if you don't have you don't know the exact start, of the infection, so it can be delayed. But if you don't have any culture result, so it's still valid and it's timely. It's the best what you have. Yeah.
So a lot of people without CF also are seropositive for Pseudomonas.
Not me.
What level?
I checked that. Sorry.
I was just wondering what level in your area and or is it a threshold effect that they're seropositive but the levels are lower than you're cutting off here?
Yeah, so that was the one of task of the manufacturer of the so who developed the kit to set the cutoff. So they work with the serum samples from our patients where we knew about their infection status before the era of modulators. So they also compared it with the other anti-pseudomonas kits, which I just mentioned there, and we checked with the general population. So quite surprisingly, maybe for you. So there was from the healthy subjects, we haven't measured any anti-pseudomonas antibodies, in their sera.
Do you know how long after the infection, the timeline when seropositivity you will see?
Sorry. So
how long after the infection? When do you see the antibodies in the blood?
Yeah.
What's
So.
the time frame between the infection and the detection of the antibodies?
Yeah. So this is the unanswered question. We don't know. So the persistence of antibodies, for how long we can still see the positivity in patients who were cleared of infection. So we don't know. So that was what I showed through the group of these free of infection, that there were almost 30% or 40% of patients positive for Pseudomonas antibodies. We are not completely sure if this is really the persistence, and we have to check on the longer term basis, so when they go back to the below the cutoff. We don't know for now.
Can I just ask, you presented at the beginning one of the slides that showed 3 different sample kits that you could have used. Why did you choose the one that you chose, and does it have any advantages over the other ones? I think you just mentioned that.
Yeah. So if I'll be concrete, so we started years ago. We started with the Danish kit, but unfortunately, because the IVDR directive, so the kit is no longer available outside Denmark. Okay. Yeah, so that was the reason why we approached actually the Czech company and asked them if they can help us with the development the kit for detection of Pseudomonas aeruginosa antibodies. So that's the kit from the company Vidia, the Czech Republic. We checked it with the company with the Germany, but it was less sensitive in our hands. So the kit which we use for our cohort is more sensitive than the one with these 3 antigens.
Okay, and then my next question, I suppose, is it sounds like you guys are using this in clinical practice to some extent, like not treating for Pseudomonas just with seropositivity, but maybe doing a bronchoscopy in a child who you haven't cultured it from. I'm wondering, and you showed 2 very good examples where this sort of changed, or you first found seropositivity and then culture positivity. Have there been scenarios that you're aware of where people have been maybe treated unnecessarily or got procedures that they...
Hopefully not. So that's there is also always a discussion, among our team, So when we've got the new serum positivity, what does this mean? If we should start, look for bacterium by other methods and maybe also do the bronchoscopy or not. So we've got quite a number of patients who are positive through antibodies, and on several occasions, and they are still just, watched, and there is no intervention. So that's on individual basis.
Okay. I just think it's interesting. We're all familiar with patients who come in with an exacerbation, and we treat, and they don't. Most of the patients luckily go up with their FEV1 and clinical status, but there's a subgroup of patients that don't improve for whatever reason, and I see stuff like this as being able to sort of fine-tune our sort of antimicrobial approach in the future, and it's quite exciting.
Absolutely, yeah. So that's what I wanted to say, with my presentation. So this is the case of the that girl, So we saw the positivity. We saw the antibody positivity. She had the pulmonary exacerbation, and then we looked again, to other samples, to find the culture positivity, and we were lucky. So maybe we had no information about antibodies, so we would say yes, she was negative for Pseudomonas, although in this case we also see the PCR positivity. So that's already like the sign of infection there. Yeah.
I just have a follow-on question. So it sounds like it is standard of care for you guys to get serologies. And if yes, how frequently are you doing it and at what age?
Yeah, so we stopped to do it for the chronically infected, so there is no, no added value of checking the antibodies in the chronically infected. In negative patients, we try to do it every time the blood is collected, so it's not done because of serum, but if a patient is indicated for the blood draw, so we also take the adequate for serum for serology detection. So it's like every half a year, every 6 months.
Thank you very much.
Okay, thank you.
Next, we'd like to welcome Dr. Jane Hill, who is going to be presenting on behalf of Dr. Antao Gao, who was unable to make it. She'll be presenting volatile organic compounds, or VOCs, distinguishing between M. avium and M. abscessus in CF sputum samples.
Yes, thank you. He's not quite a doctor yet, but I know he was thrilled with the opportunity to present here, so thank you for that. Right, I'm going to talk to you about NTMs. Thank you for the great session so far. Don't leave yet. It's very exciting. I'm just kidding. But only if I can advance the slides. Is it this click? This, that, that? Oh, whoa. We have no relationships to disclose. Excuse me. All right, so NTM infections, maybe these are the black sheep of the family, but they're becoming more popular. Non-tuberculosis mycobacteria, obviously, for NTM. And they're a lot like Pseudomonas in terms of their environmental. There are lots of species, and a bunch of them are opportunistic pathogens. NTMs can infect you in all sorts of places, unfortunately, but very often pulmonary. So cystic fibrosis is one NTM risk factor, and in fact, around 10% of people with CF have a prevalence, essentially one or more positive culture for NTM, and some of them more often, of course. And of course, it can cause pulmonary infection in those patients. The most prevalent groups are M. avium complex and M. abscessus. And how do we diagnose an NTM infection? It's complicated, right? Because NTMs can cause disease. They can be indolent, and they can be intermittent infectors. That's typically captured by collecting microbial culture, looking for clinical symptoms and monitoring them over time, and radiography. If you use microbial culture for NTMs, because they take a bit longer than most of the other bugs, then you have to do some serious decontamination, which reduces the culture sensitivity to detect them. And of course, we have the issue that's been a theme throughout this session, is that folks on highly effective modulator treatment, at least at their clinical visits, are producing less sputum on average. Maybe we can all do in-home collections, though. And the symptoms and radiographic evidence can be caused, of course, not only by NTM. So it's quite a complicated process to diagnose a full-on NTM infection. And indeed, it can take months, right? So 4 to 6 months to actually come up with a conclusion. And it's good to take that amount of time in some ways, because once you decide a person has an NTM infection, then they go into treatment. That treatment lasts a long time. So you've got to be careful. So we're interested, along with others, in developing a much faster way to detect these infections and also to determine if disease is present. So we, along with some others in this room, are working on a novel diagnostic method using exhaled breath to figure out who's present in your lungs. And breath contains many, many molecules, thousands of them, in fact, and some of them have been linked to specific diseases or infections. So we aim to discover lots of things, we hope, with breath, including whether or not we can discern avium complex from abscessus complex in people with CF. There's treatment decisions that are differential for those two groups. Oh, yes, why important? Sorry, these are not my slides, so bear with me. MACs and MABs are the two most prevalent sort of groupings for people with CF, and as I mentioned, differential treatment regimens. So our workflow is that we receive samples. This is through the Patients and Predict sort of network that Dr. Nick and others have been running for a while now. So we'll receive a sputum sample from their greater network. And then we put that sputum into a little container, and we stick a little fiber inside of that container that absorbs the volatile molecules that are emanating from the sputum. We do a little heating and a little mixing to enhance that process. And then we disgorge those contents, those molecules from the sputum into an instrument that allows us to then measure the contents. And of course, sputum is not breath. We do a lot of work on breath, but we have access to hundreds of samples through Patients and Predict. So we're using it as a proxy in this case. In order to figure out from those thousands of molecules which of them might be relevant for discriminating between MACs and MABs, we do some identification of the peaks that are found, those compounds. We remove the things that come from our sampling process. We normalize data, and we employ models and statistics. Here's an example of a GC by GC chromatogram. So we use an instrument that's called a two-dimensional gas chromatography time-of-flight mass spectrometer. It's a long word for a very cool piece of equipment that allows us to separate the molecules that you find in the headspace of sputum or in breath into their respective compounds. So this may not mean anything to you, but it's pretty for those of us who like chemistry. This is an example of a 2D chromatogram, and this represents a compound peak, putative peak. So here are some preliminary results to look at the differentiation between MACs and MABs. Now, because I'm tight. So we actually have hundreds of samples from hundreds of patients in this study. About 400 samples is the total number. But we've restricted our initial analyses to looking at folks who cultured positive on the day of sputum collection. And then we've expanded out beyond that, which I'll explain in a moment. So that's here. All right, so I'm going to show you three sort of graphics to look at the difference between MACs and MABs based on their volatile profile. On the left is a principal component analysis plot to visualize that data, a t-SNE plot, which is another version of looking at things visually, as well as a heat map. So in the PCA plot, we're looking at 8 markers in the headspace of sputum that relatively does a pretty good job of discriminating between those two groups that we're interested in. As I mentioned, all based on sputum culture. This is a t-SNE plot, so looking at the same data, the same 8 molecules, but in a slightly different way. And then as a heat map, which I think kind of gives you almost a better sense of things because you can see proportions and the misclassification a little more easily. Now, we know that this data is probably complicated by many things. We're basing our analysis categories on culture data. There's currently some great work being done by Dr. Nick's group and colleagues that are looking at the molecular information that's contained within those samples so we can get some greater discrimination and perhaps reclassification of some of these samples. We have not included co-infected samples in this analysis yet. Here are some of the biomarkers that we found. I haven't given you a name, but I've shown that 4 of them in that number of 8 that we're using to do the discrimination are actually statistically significant. But you can see that there's still a lot of variability in there. And on such small numbers, it probably should be expected. Now we expanded our categorizing into samples that have been positive for a MAC or a MAB, but within 30 days of the sample collection that we were sniffing, if you will. And here's the same kind of flow of information, a PCA plot, a t-SNE plot, and a heat map. And this is using 10 volatile biomarkers. So we had to expand the potential compounds to do this discrimination over that 30 days. And you can see it gets a bit more messy. You can see in the PCA plot, you can see it in the t-SNE plot, and again, it's represented here in the heat map. We have done some modeling on this data despite the small numbers, and we're reasonably able to separate our MACs and MABs. So it's another way, again, of looking at the data that I've just shown you. Using 2 different tools. So one of them is a machine learning tool called Random Forest, a decision tree, and the other one is a partial least squares discriminant analysis. And they're both showing essentially the same thing, reasonable, not terrific separation. And again, we have some significance in some of the markers that we see within these patients. So not all of them show statistical significance, and maybe more of them will as we increase the number of samples in these categories. But we'll see. That's optimism. So some conclusions, early conclusions. We can do some level of discrimination, right, between these samples by sniffing the head space. But there are many next steps to do in order to see if this is real, to see how far back we can look in terms of culture positivity for these organisms and whether it holds. For many of our patients, we will have some patients that will culture positive many times, essentially every visit. And in others, it might be once a year or even 2 years ago in some cases. So we don't know if what we see the day that we get our sputum that we're sniffing, if that's going to translate to greater time. In addition, the culture samples that we're using to sniff are not the same, sputum samples that we're sniffing are not the same samples that are sent out for culture. So you can see that might be a little bit of a problem. Breath may take that into account because it's a more holistic way of sampling the lung, but our sputum data will be constrained in that way. So some of our next steps, increasing our sample size. Luckily, we have many samples in this study. I think it's over 400 at this point. And then we're going to expand, as I mentioned, the gates for the days. We have different analytical batches. So as you might imagine, you run a sample 1 year. In terms of chemical analysis, if you run a batch of samples the following year, you have to do some aligning of those samples in order to have the data talk to each other. So we're working on ways to do that. And of course, we have to deal with co-infection and what do you do when your molecular work doesn't coincide with your sputum culture positivity, and try to aggregate those together. Additional work that we're trying to look at is whether or not we can use the sputum volatiles and also breath volatiles to distinguish between disease and intermittent infection. And we have some early data that suggests we might be able to do that. The question is, how early can we do that? Because that's the key, right, for everybody. This is my fabulous group, and we're also very grateful to the whole Patients and Predict team run out of National Jewish Health, and of course the Cystic Fibrosis Foundation and NIH for funding. And with that, I'm happy to take questions.
Great, many thanks for a great presentation. I think we've got at least one question that I can see right off the bat.
Oh, hey, Gina.
Yeah, great talk. I'm just curious, sniffing the sputum as opposed to collecting breath, like, what's your thought? Like, are there differences, or is it similar in your previous work?
So the question was, if I can paraphrase, is there any overlap between what you see in sputum and breath? And is that?
Yeah, just like, are there differences, like sniffing the sputum versus collecting breath and the analysis? Like, how does that? Have you ever compared the two?
Yeah. Thank you. Yes, so we have done a limited comparison. So very often we're funded to do one thing and not the other. We try to sneak in the other where we can. We tracked I'll give you one singular example. We've tracked a patient who was on phage therapy in order to eradicate M. abscessus. And we collected breath and sputum data from that patient over a very long time course. And we did see concordance, nice concordance and overlap. But it is, we don't always have access to that data. And we've talked amongst the team about doing exactly that study, not only for CF, but some of our other areas, because I think that's a good question. We feel that lavage fluid sniffing and sputum sniffing can give us at least a good proof of principle. And then from that, we can expand out to breath. And I do expect, however, breath to be better in some ways, because it should theoretically be sampling the entire lung, not just an area that's coughed out, right, from sputum. But that's a hypothesis only.
Did you see any differences, or have you observed, have you checked for other so Pseudomonas infections versus differentiation between the different types of NTMs.
Yeah, the question was whether we've looked at anything else basically using this approach. And the answer is 100% yes. In fact, Pseudomonas was our first love in this regard. And there will be at least a poster on this. And we presented on this last year, actually. So Pseudomonas is, for reasons that I'm still astonished by, incredibly visible in the breath, if I can put it that way. And we've seen essentially an accuracy rate that approaches 90% for being able to discern if a patient has a Pseudomonas lung infection at the time of culture, and we think even through Leeds criteria kind of timeframes. And that data is being validated currently in a study that I'm conducting with Heather Bean, Dr. Heather Bean and Edith Samanek. And the data seems to still be holding through a couple of hundred patients in that study.
The fingerprint different to the NTM?
Yes, sorry, excuse me. Yes, and of course that meaning that Pseudomonas has a unique profile compared to, for example, staph or other organisms. I don't think we've been at all comprehensively able to profile everybody, and that's mostly a numbers issue. We have done animal studies where we've looked in the breath of mice and found unique signatures for Haemophilus steno and so on, but we haven't had the numbers yet in CF to expand beyond Pseudomonas, staph, and NTMs.
I had one question for you, if I may. And I think you may have been sort of approaching that at the end of the presentation, but I suppose it's just thinking about not being surprised that there are certain volatile organic compounds that are shared between abscessus and ABM complex.
Yeah.
But I'm quite interested in, because of course some people will culture this and it doesn't cause disease. Are you seeing different biomarkers that are maybe shared between the two when they're organisms that are causing disease?
So I'm not sure we've asked the question with that nuance about disease, like the underlying sort of clinical context. But we have seen, for example, not in CF, but in Mycobacteria tuberculosis, a differential profile between folks who have active disease and latent disease. Whether or not it's pushing up against subclinical TB is, I think, a little bit of a question in that data. But it looks like the overall, that we can see overall a difference between that. And we presume it's related to inflammation as well as some of the off-gassing of the organisms themselves. And indeed, that's backed up at least a little bit on looking at when those folks go onto treatment and they revert back down to a less inflamed, more latent and healthy kind of breath print. We don't have quite enough data on people with CF to know if that's true, but we hope to look at some that we've been collecting over time in people with CF who have a Pseudomonas infection. And we'll have some from the patients in PREDICT study for folks who are on NTM treatments.
Thank you.
Thanks. Oh, any other questions? Sorry. Great, thank you.
We're about at time.